Hey, good morning, everybody. My name is Ed Kaiser. I'm a family trained nurse practitioner. Really excited to be with you guys today. We'll be talking about um, understanding sort of the benefits of medicated assisted treatment for substance use disorder. So, a little background on me: I'm a family trained nurse practitioner. I live in Omaha, Nebraska. Started out in sort of ER urgent care setting, and then for the last 7 years, I've been working for a company that treats substance use disorder all over the United States. Really thankful to be with you. I want to start our time off today just by kind of telling you a brief story. One of the doctors that trained me in how to provide treatment for substance use disorder, he tells this story when he was working in the ER. He was doing some continuing education courses. And so we're going to talk a lot about Suboxone today. Buprenorphine is the other name for that. But he was doing training to be able to prescribe Suboxone, just really to complete continuing education hours. And he was sort of in and out. So he had to have like 15 hours back then to be able to prescribe. So he was like doing the training while he was working, completed the training, and then a few months later, a DEA agent showed up in his emergency room and was asking him about him completing this training. And so, as a medical provider, anytime the DEA shows up at your location or where you work, you get a little bit nervous. And so he walked out there to meet the guy and said, "Hey, listen, I did the training, but I haven't prescribed the medication. I haven't done anything wrong. I just want you to know that." And the DEA agent looked him in the eye and said, "Listen, you need to be prescribing this medication because this medication is going to save people's lives." And that was such a mismatched experience for this provider that he began to sort of look into what this agent was talking about and learn more about the medication and the treatment. And so the only thing I would add to that is it does not only save people's lives, but it really helps people get their lives back. And so my hope today is that we get to talk more about sort of the treatment of substance use and opiate use disorder and help you kind of better understand the medications and what's out there to help people. So these are our learning outcomes for our time together. We'll talk about the importance of medicated assisted treatment. I want to spend a little bit of time with you kind of talking about the disease of addiction, which now we refer to as substance use disorder. We'll talk a little bit about some of the different medications to treat substance use disorder, and then again, more specifically about sort of buprenorphine or the medication Suboxone. Again, those are the same thing, and how that treatment actually works. And then talk to you a little bit too about how to keep patients safe in and outside of the correctional facilities. This just shows us a little bit of the agenda where we'll go. We'll talk about statistics first, a little bit about stigmas, the disease process, medication, a little bit about diversion and dosing of the medication, and then some of the benefits and safety of the medication. I included this slide for you. This is just a picture of some of the correctional facilities that Ideal Option works with. Now, I'm mainly just doing patient care. I'm not doing work inside the correctional facilities, but I do want you to know that the company I work for, we've done work inside of correctional facilities where we've initiated patients on medications in those settings, and so I think that we can be a helpful resource. Again, I think that there's 45 correctional facilities that we're working with right now, and so those are mainly in kind of Washington, Oregon, Montana area, but we do have some experience in that area. All right, let's look at some of the statistics together. So, as far as prevalence of substance use disorder among incarcerated individuals, approximately 65% of the US prison population has an active substance use disorder, which is pretty a high number, at least it felt high to me. And then around 85% of inmates have either a history of substance use or they've committed crimes that have been related to drugs or alcohol. So those could be, again, distribution, property crimes, things to maybe support their drug habits. As far as criminal behavior related to substance use, 50% of incarcerated individuals would meet the diagnostic criteria for drug dependence or abuse. So again, there's questions that we can ask individuals about that diagnose them with substance use disorder, and 50% of those would qualify if you ask them. And then a large portion of crimes that are committed, again, are drug related, with about 40% of the people arrested for property crimes reporting that they committed the crime, again, to fund their drug habit. And then this last number here on this slide, incarcerated individuals with untreated substance use are at a high risk of recidivism, There's some studies that show 60 to 80% of individuals with untreated substance use disorder are going to relapse to drug use after release. And again, that's going to contribute to a really high rate of reincarceration. So again, the world that I work in, patients sometimes are coming out of the correction facility, sometimes they're on work release, but generally they're coming to see me out of their own will. They're wanting help, and oftentimes I'll ask patients when they're stabilized in our program, they've been on the medication for a while and they're doing well. I'll say, hey, tell me what was your life like prior to sort of being on Suboxone and being in a treatment center or treatment program. And so often individuals tell me, like, hey, there's things that I've done in my past that I'm not proud of, things that I never thought I would do. And when you talk to an individual that's getting the treatment that they need, it's almost you're talking to like a different person. Like they can't believe some of the things that they were willing to do in their past. And so I share that with you just to say, hey, it really is interesting and helpful to be able to help people get the help that they need. And I think this really can have a huge impact on specifically the recidivism and people going back to use after they get released from incarceration. A few more statistics for you. Despite sort of this high prevalence of substance use disorder, access to treatment in correctional facilities is definitely limited. Around 11% of inmates with a substance use disorder receive any form of treatment during incarceration. Though again, comprehensive treatment programs are shown to be really helpful. When you talk about substance use disorder, a lot of times you got to talk about mental health as well. So 50 to 75% of individuals that have a substance use disorder also have a co-occurring mental health disorder. That may be depression, anxiety, post-traumatic stress disorder. So again, it's not just a simple thing that we're treating. It obviously is sometimes more complex. And then while medications for assistive treatment like methadone, buprenorphine, naltrexone, we'll talk about all of those individually. They're really effective for opiate use disorder treatment. Fewer than 1% of incarcerated individuals actually receive medicated assisted treatment while they're in prison. So even though this is recognized as one of the best practices currently for treating addiction and opiate use. So we're really hoping that we can make an impact on that number. And then the evidence shows that if you provide substance use treatment during incarceration, we're going to reduce recidivism rates by as much as 30%. So it's going to really improve long-term outcomes. People are able to get jobs, stable housing. Really, like I said earlier, it really allows people to have a chance at getting their life back. And so that's one of the reasons I'm so excited about treating this population. Let's talk for just a minute about some of the stigmas that are sort of associated with substance use disorder. One of the common ones is that substance use disorder is a moral failure, or that individuals just lack willpower, lack self-discipline. And so again, this sort of stigma is really rooted in not believing that substance use disorder is a disease process, that people just choose to continue to use drugs or alcohol out of laziness or selfishness or something like that, and they don't really fully understand maybe the chronic or the complex nature of addiction. Obviously, criminal behavior is associated with that. Maybe people are untrustworthy or unreliable. Once an addict, always an addict. Some you may have heard that before. Again, a lot of times we try to blame the individual, and so society, as a whole, sometimes holds people with substance use disorder solely responsible for their condition, and that can sometimes ignore some of the influence as far as genetics, trauma, mental health, environmental factors, things like that. So again, we'll talk more about that as we go through our time together. And then people can also develop a self-stigma, which means that they sort of internalize these things that they hear about themselves. They start to believe that they're worthless, unlovable, and really incapable of change. And this can really delay individuals from wanting to seek treatment. And so, again, I think understanding some of our own stigmas and just culturally our stigmas can help us understand what these patients are going through, and even be more compassionate to try to help them get the treatment that they need. All right, let's pivot now and talk a little bit about the disease of addiction. So addiction, or what we say now is substance use disorder, again, it's a complex condition that's sort of characterized by this compulsive engagement in behavior and this repeated use of substances. Again, we now instead of say addiction, we call it substance use disorder. But what I want to highlight for you is that people with substance use disorder, they start out with a normal brain. So their brain is a normal brain like you and me. And what ends up happening is the reward system in their brain gets hijacked by this substance of abuse. And then chronic sort of use of that substance results in these persistent changes to the brain chemistry that we can actually see on imaging that sort of drive this manifestation of the disease where there's this compulsive drug seeking behaviors despite the harmful consequences to the individual. The cause of substance use disorder is multifactorial. So it's a combination of behavioral, environmental, and genetic factors. And then again, we view this as a chronic disease. So it's a relapsing, remitting disease process that generally can be managed, but not usually fully cured. And so again, when you think of other like chronic disease processes, sometimes like diabetes or high blood pressure is helpful to think through. A lot of times individuals that struggle with those disease processes or have been diagnosed with that, a lot of times they have to take medication for the rest of their lives. They may have to obviously change their diet and their exercise and things like that. But you never think of somebody with diabetes as like, oh, we're going to cure that person. What we're more thinking through is like, hey, we're going to help them manage that disease process to be able to live longer, to live healthier. And so, again, I want to try to shift your mind around substance use disorder that it's a chronic disease process and try to view it in that way. Excuse me. Okay, so let's look more closely at the genetic and environmental factors. So genetic risk factors account for about half of the likelihood that an individual will develop a substance use disorder. Genetic risk has been associated with common variations in the dopamine opiate receptor, so we can see that genetically in individuals. And again, we don't get to pick our genetics, right? We're just born with that. The environmental side of things is really interesting to me as well. The odds of developing a dependence on alcohol, cocaine, or opiates, it really nearly doubles for every unit of increase in the number of ACEs. And ACEs can be measured by like adverse childhood experiences. So I think it's like a 10 question scoring system, but it talks about abuse, whether that's physical, emotional, sexual abuse, neglect, household dysfunction, traumatic experiences. And again, for every one of those things that someone answers yes to, it almost doubles their risk of developing a substance use disorder. And so, again, just highlighting here that the environment that people are growing up in really plays a significant factor in their developing of the substance use disorder. So let's look a little bit more at the sort of the reward circuitry in our brain. And again, the reward area of our brain is in the limbic system, and this is known as the primitive brain. And this includes a number of important structures that are involved with emotional and behavioral responses to our environment. So the way this reward pathway is supposed to work is it's supposed to promote life-sustaining activities, okay? Activities like sex, eating, drinking, socialization. This area of the brain regulates the ability to feel pleasure in response to these behaviors that are essentially necessary for survival. And then because of that, it motivates our brain to repeat those behaviors. And again, in an active, healthy individual, these life-sustaining activities are what drive us to continue to repeat that. But also, substance of abuse activate this area of our brain in a much stronger way. One thing to sort of keep in mind, and I think is helpful for us understanding substance use disorder, is to understand that the primitive sort of area of our brain is essentially blind. And what we mean by that is its only thing that it really understands is dopamine. Again, the brain is much more complex than what I'm describing, but this part of the brain doesn't care about rules. It doesn't care about behavior. It doesn't care about social implications of what's happening. It's only reproducing this behavior that creates this dopamine believed for both survival and pleasure. So, as you can imagine, the greater the dopamine release with a particular behavior, the greater the importance that our brain assigns to that behavior. And memory around that high reward behavior becomes solidified and assigns motivation and value when we have chronic exposure to that behavior. So this slide sort of just highlights dopamine reward in our brain. And so at a baseline, we need about 50 units of dopamine just to have the motivation to sort of do normal daily activities. If we get into a low dopamine state of 30 to 40 units, we're going to have fatigue and slow movement and things like that. But again, as you go across the board, I think that the brain's ability, an average human being can release about 100 units, and that's generally for like an orgasm. And again, in that situation, the brain is thinking that we're reproducing and we're trying to survive. A good food can give a good release of dopamine, but then as you go across the board, cocaine, tobacco, alcohol, heroin, methamphetamine, you can see how much more significant the units of dopamine release is. And so this is helpful for us to understand what's going on in the individual, and it helps us understand how the medications that we use to treat can help rewire people's brains. Excuse me. Chronic exposure to substances abuse can develop two things. One is a tolerance. So individuals need a higher dose of the substance to sort of achieve the same effect. But eventually what happens as well is people develop a dependence on the substance. And then when they don't have the substance or the drug, they get into what's called these withdrawal symptoms, which are like body aches, sweats, irritability, just like really bad flu type symptoms. And so as people use substances over time, this graph helps us see that initially they're experiencing this euphoria, but eventually with chronic use of substances, patients are no longer experiencing euphoria. They're really just using substances to try to feel normal and not feel sick. And this can be a really difficult place for people to be because they have to continue to use substances just to feel normal. Again, it's hard for us to sort of put ourselves in a situation or help us understand what it's like to have a substance use disorder. But imagine with me, if you would, that you have been without food for like 3 to 5 days. What's going to start happening is your brain is going to start subconsciously messaging you that you will die unless you get food. And as a result of that, you're going to start compulsively thinking about food. You're going to be contemplating ways to put yourself in a position to access food. And then potentially you're going to be willing to do something, maybe steal money or something like that to be able to get food. And what's going to happen is it's just going to consume you. There's going to be an overwhelming sort of subconscious desire to find and ingest food. Again, and that's what sort of like this craving or desire to use is like for the individual. And again, they're physically ill or sick if they don't have it. I do want to highlight here that there can be a difference between somebody who has a dependence on a drug versus a use disorder. And so dependence essentially just describes a physiological state, where use disorder is a sort of array of behaviors that are compulsively using substances that lead to social impairment and risky use. Patients who are prescribed chronic opiates over a period of time that are taking it correctly are going to have a dependence on that, but they may not have the characteristics of an opiate use disorder. So I just want to sort of highlight the difference in that. All right, so we talked a little bit about the statistics and some stigmas associated with the disease and kind of understanding more of the disease process. I'm going to pivot now and talk to you about the different medications that are available specifically for opiate use disorder. And I think that this is really important if you can hang with me through it, because it helps us understand the way the medicine works. And I think that can give us a better understanding of how the treatment can be really helpful for individuals. Excuse me. All right, essentially there's 3 FDA-approved medications for opiate use disorder. One of those medications is methadone. Methadone has been around for a really long time. It's been really helpful for a lot of individuals. But what I want you to know about methadone at this point is methadone is a full opiate agonist. So it sits on the opiate receptor and it turns it on in a full way. It's a long-acting opiate, but this does allow patients to get off of short-acting opiates like fentanyl and oxycodone and things like that. But it turns it on at 100%. Buprenorphine, again, buprenorphine, Suboxone, using that simultaneously, but or interchangeably. It activates the opiate receptor to a lesser degree, so it gives a partial opiate effect. So think of it as like turning on a faucet. We're turning this faucet on at about 30 or 40%, not at 100%. And that's how buprenorphine activates that opiate receptor. So it activates it in a lesser way. Naltrexone does not activate the opiate receptor. Naltrexone is strictly an opiate blocker or antagonist. So it sits on the opiate receptor in the individual's brain and just blocks it so that no opiate activating substance can get on there, including buprenorphine or methadone. So generally speaking, that's how those three medications work. This chart sort of gives us a broader view of some of the advantages and disadvantages of methadone versus buprenorphine versus naltrexone. So one of the good things about methadone in the top left here is that it can achieve a greater opiate receptor activation. And again, that's because it can turn that receptor on at 100%. There's not risk for precipitated withdrawals, and I'm going to talk to you more about what precipitated withdrawals are in the next slides here. Some of the disadvantages of methadone, there is a higher abuse potential of methadone, so much so that generally speaking, you have to go to a daily observed dosing location to be prescribed methadone. Now, I think there's some laws coming out where there's been some lessening on those requirements, but currently patients have to go to a location every single day and take their oral dose of methadone. And as you can imagine, that can be really a deterrent to people trying to go on with their daily lives, trying to get to a methadone location. Buprenorphine, one of the advantages, again, buprenorphine or Suboxone is a decreased abuse potential. So not as much of a concern of abuse. It does also provide opiate blockade of the opiate receptor, and we'll talk more about that as we go. One of the nice things about this, it is available through pharmacies, so you can prescribe this medication. And now any doctor or nurse practitioner mid-level that has a DEA license can actually prescribe Suboxone. Patients can pick it up at the pharmacy and they can take the medication at home, so they don't have to go to a special place. It does come in both an oral form as well as an injectable form, so that's nice. There is potential disadvantages of precipitated withdrawal when you're initiating onto the medication. And so there are some things we have to do to help patients get on it. Obviously, another disadvantage is there is concern for diversion of this medication where patients are not taking it like they're supposed to. And then finally, on the far right, naltrexone, advantages of that medication. Again, this is an opiate blocker. There's not any physical dependence on naltrexone. There's not any significant abuse potential. There is the disadvantage of you have to wait about 7 to 10 days from your last opiate use before you would start naltrexone. And there is significant risk too of fatal overdose after discontinuing this medication. And so although this is an FDA approved medication, we do not use it very often. And mainly that's the concern is that if they don't have any tolerance to the opiates and they stop the naltrexone and they have a one-time return to use, there's a significant risk for overdose in those individuals. And so one of the reasons that we steer away from that one as much. All right, let's talk for a few minutes about precipitated withdrawal. Essentially what this is a condition that occurs when an opiate agonist, so we're talking about methadone, heroin, fentanyl, some sort of activating agent, is displaced or removed from the opiate receptor by an antagonist, i.e. naltrexone or naloxone, an opiate blocker, or a high affinity partial agonist like buprenorphine. And so essentially what happens here is on the left side, the green is like representing sort of an opiate that's on there. And when that opiate gets removed, the amount of dopamine goes from, we'll say 100 down to like 40 or 100 down to 0. And that's what causes this severe withdrawal symptom for the individual. Now, again, in certain individuals, we want this to happen. If they're overdosing on fentanyl, we give them Narcan to reverse the dopamine, and we want that to stop so that they start breathing again, right? But when patients are starting on treatment like buprenorphine, or if they take something, that this really is a deterrent for them wanting to start the medication because it really is a terrible experience. The way that patients describe this to me is like they describe it as like they only make this mistake once. So if they end up taking Suboxone on the street, after they've used fentanyl or some sort of opiate, if they take it too soon, the experience is so terrible that it's like, I'm never going to let that happen again. So it's one of the disadvantages and one of the reasons we got to help people sort of initiate on the medication safely. I want to spend a little bit of time on this slide, and this is more focused on the mechanism of action of the buprenorphine or Suboxone. So again, it's a partial opiate agonist, so it sits on there and it turns the opiate receptor on at like 40%. Okay, methadone again turns it on at 100%. This one turns it on at 40%. Another thing that's really cool about the Suboxone is it has a ceiling effect. And what that means, because it only turns the receptor on at 30%, if a patient takes more and more Suboxone, so generally a maximum dose of Suboxone is 24 milligrams a day. If somebody takes 32 or 40, or if they take their whole prescription bottle all at once, essentially what's going to happen is there's only so many opiate receptors that are available in your brain. And so if there's more medication, not any more of those can get on the opiate receptor. And so it's still going to turn it on to a maximum of 40%, but not any higher than that. And it helps prevent people from overdosing in that situation. Another really cool thing about this is even though it turns it on at 40%, generally it activates the opiate receptor enough to help the patients get past the withdrawals and the cravings to desire. So that slide that we looked at where patients are feeling this withdrawals and they're just using enough substances to feel good, this is going to be able to activate it enough for them to sort of feel normal and to give their brain time to like adjust to having a normal amount of dopamine on a more regular basis. And then one of the probably the most cool things about this medication is it has a higher affinity for the opiate receptor. And so what that means is it is more attracted to that opiate receptor than other opiates. And so in this little picture, we're depicting like fentanyl or oxycodone or methadone. If any of those are in the patient's system and they also have buprenorphine in there, the buprenorphine is going to sit tightly on that and it's going to remove those other things. And essentially what this does is it prevents people from overdosing. If they have Suboxone in their system and they get in a situation where they use fentanyl or other opiates, the Suboxone is actually going to block that opiate from getting on there. It's going to prevent them from getting high, and it's going to prevent them from overdosing. And so it's a really cool way that the molecule works to help prevent people from, essentially from overdosing if they do have a return to use. This slide here sort of just highlights again the ceiling effect of the medication. So at the bottom of the slide, the dosage as it increase, and on the left side, we're looking at the intensity of the opiate effect. So full opiates, heroin, fentanyl, oxycodone, the more of that you take, the higher the levels will get, and then you're going to cross this threshold where you could theoretically overdose from the medication. Buprenorphine or Suboxone is not like that. As I was mentioning before, you can turn up the dose on that as high as you want, but eventually you're going to get to a ceiling effect where you're not going to get any more of this opiate dopamine activation because it's only turning that receptor on at about 30 to 40%. One of the unique things about Suboxone or buprenorphine is that the medication is taken sublingually, which means that you put it underneath your tongue and you allow it to dissolve. And most medications, obviously, we swallow, but this one is a little bit different. And so the reason that it's taken sublingually, there's a couple different components to it, but essentially it's related to the percentage of the administrative drug that sort of reaches our circulation. So if you take buprenorphine and you just swallow the medication, only like less than 10% of that medication is being activated for the individual. Excuse me, when they take the medicine, put it underneath your tongue, take it correctly, about 30 to 35% of the medicine is absorbed. And then if somebody would take Suboxone and try to abuse it, either by injecting it IV or snorting it, a much higher amount, so like 100% of that medicine would be activated in the individual in that situation. So that's again what the reason that we take it sublingually is partially due to how it's absorbed. Another part of Suboxone that we need to understand is essentially it's the difference between naltrexone and naloxone. And these words are very close, is very confusing for individuals, both patients and family members of understanding this part of the medication. But essentially, Naltrexone, this is what we've talked about before. This is the FDA approved medication. It's a long acting opiate blocker. Okay. We use it for both opiate use disorder and alcohol use disorder. And essentially, it comes in a pill form that you swallow, or you can also get an injection. Okay. Naloxone, the way that you remember naloxone is think of Narcan. So that's the same agent as Narcan. It's a short acting opiate blocker or antagonists, and we use it to reverse overdose in individuals. So if somebody's overdosing, we give them a spray of Narcan. It blocks that, removes that medicine or the opiate from there, and that's the way that part mix. So naltrexone short acting, naltrexone long acting. See, I even get it mixed up. Naloxone short acting. The question that a lot of people have is, why is naloxone added to the Suboxone medication? So, as I'm referring to buprenorphine, Suboxone, I'm talking about a combination drug. Suboxone is buprenorphine and naloxone. So both of the medications are present in the medicine that the individual takes. And the only reason that the naloxone is added to the buprenorphine is essentially as a deterrent for misuse. So if somebody would take Suboxone, combination drug, and use it IV or nasally inhale that, this naloxone component is going to be activated. And theoretically, the individual is going to experience something similar to a precipitated withdrawal that we talked about before. So they won't experience the buprenorphine because the naloxone component has a higher affinity even than the buprenorphine. And so it's going to block that receptor. And so at the bottom of the page, you can see if naloxone is taken orally, so if somebody swallows this medicine, less than 1 or 2% gets absorbed. If they take it sublingually, so we take Suboxone, put it underneath your tongue, less than 5% of the naloxone is absorbed into their body. But if somebody takes it intranasally, so if they snort it or if they inject it, this naloxone gets added or gets activated in a much more significant way. So again, as simply as I can say it, the only reason that the naloxone is added to this medication is really to prevent abuse of Suboxone. If somebody's taking the medicine correctly, it does not do anything. But if somebody takes it incorrectly, it becomes activated and they have a negative response to taking the buprenorphine or the Suboxone combination medication. One of the questions we get a lot of times is both from individuals and family members is how long does somebody need to be treated with Suboxone or buprenorphine? And again, essentially the current data is the longer that somebody is on the medication, the better the outcome is going to be. So indefinite treatment with buprenorphine is recommended unless the individual wants to come off of the medication and they're making an informed decision to stop the medication. Now, practically speaking, in sort of my own experience of treating patients over the last 7 years with substance use disorder, a lot of times patients don't want to be on a medication that they're going to be dependent on, right? I generally recommend at least 6 to 12 months of stability in their life where they're taking their medication, where their dopamine levels are relatively normal, where they're able to live their life, not have a return to use, things like that. Generally speaking, when people are getting their lives back and they start doing better, around year 2 or 3, they start to ask the question of like, hey, I want to get off of this medication. And so there's ways that we can help individuals slowly wean off of Suboxone by just taking less medication. Or sometimes we use the injectable form of buprenorphine, which is a longer acting shot form. And sometimes that can help people get off the medication as well. So again, we're not trying to keep people on Suboxone for the rest of their life. We want it available to them if they need it, but if somebody wants to come off of it, they can stop using the Suboxone, and we definitely help people do that in our practice. But again, thinking of a chronic nature of a disease process, right? The duration of treatment for diabetes or hypertension medications, oftentimes patients are taking those medications for the rest of their lives. All right, thanks for hanging with me through that. Let's kind of transition now a little bit and talk about sort of the diversion and dosing instructions of the buprenorphine or the Suboxone. So again, what is diversion? In a healthcare, diversion refers to the unauthorized sort of redirection of medications or prescriptions drugs. Particularly, we're talking about sort of controlled substance. So where they're not doing their intended need to the purpose of the individual, but it's being given to somebody else. So specifically with medication-assisted treatment, diversion rates in the outpatient setting, specifically like buprenorphine, methadone, ongoing research, but these are some of the most commonly diverted medications that are out there. Some of the studies indicate between 16 to 25% of buprenorphine may be diverted, though again, not always for misuse. Individuals who are using the diverted buprenorphine, sometimes they're doing it just to avoid the withdrawals and to help stabilize their condition until they can access more formal treatment. So just as access to treatment is difficult inside the correction center, access to treatment for individuals outside the correction center is also difficult. Again, generally patients are not using Suboxone to get high or abuse it in that way. They're generally using it because they're getting sick and they're trying to avoid sort of this withdrawal state. Again, the goal would be not for the medication to be diverted, but I often see patients that come to me for the first time and they say, hey, I tried some Suboxone off the street. It actually really helped my withdrawals and cravings, and now I'm here to actually get a prescription and do the treatment because I want to be done using. And so, again, that's not the ideal situation. But I think I'm just trying to highlight that, like, even though this is a highly diverted medication, it's often not being used in ways that where people are using it, I would just say maybe inappropriately or for reasons of like getting high or something like that. So, but nonetheless, it's a diverted medication, and we need to do work to try to avoid that from happening. And then in the more specifically, diversion is a concern within correctional facilities as well for medications like Suboxone to treat opiate use disorder. Again, exact percentages are hard to know, but they can be mitigated by different sort of policies, security measures, population, but estimates are around 20 to 30% that this medication can be diverted within the correctional facility. So diverted outside the correctional facility, diverted inside the correctional facility. And so what things can we do to sort of help prevent this? And there's a few different options that we have and the things that we implement too as we're working within correctional facilities. But preventing diversion can sort of be a combination of different strategies. And one of the best methods, I would say, is probably just direct observed therapy. And so essentially what this looks like is the individual comes for their medication. You sort of like shine a light in their mouth, make sure they don't have anything in their mouth. They're not trying to pocket or cheek the medication. The patient is given the medication. They put it underneath their tongue. They go sit down in a chair. Obviously, sometimes they put their hands, they sit on their hands. Essentially, they're just sitting in an isolated area. Generally takes about maybe 10 or 15 minutes for the medication to dissolve. While it's dissolving, they're trying to hold that medication in their mouth. After that point, the patient or the individual can spit the medication out or they can swallow it. It doesn't benefit them really to swallow the medication, but it's not harmful to them. And then once the dosing time is over, if they spit that out, then you kind of shine a light, make sure they don't have anything else in their mouth, and they're done. So that's one of the most common ways that we try to avoid it in the correctional facilities. And probably most of the places where we're doing the oral medication, they're doing this direct observed therapy. Another option is the extended release medication. So buprenorphine, the active ingredient in the Suboxone, again, comes in extended release of Sublocade or Brixadi. So you can get a shot form that's once a month. And again, this is maybe better than daily dosing. You don't have to monitor the individual. You give them a shot, and then they get the medication, and they have the medicine in their system for about a month. So that can be another really helpful tool if that's available to prescribe the extended release medication. Tamper-resistant medication, again, this is the formulation of buprenorphine that is combined with the naloxone. So we kind of talked about that, but Suboxone is the brand name of that. And again, it's designed to be tamper resistant. The naloxone reduces the effects of the buprenorphine if it's injected or snorted, and also can cause that negative sort of precipitated withdrawal. And essentially, using this medication makes it less desirable for diversion in the healthcare or in the corrections setting. Obviously, we want to educate and train the staff of the individuals about the purposes and the benefits of the medication and try to reduce the stigma around the treatment of it. And I think that having access to treatment and understanding it can really help minimize some of the incentives to divert the medication. Again, if the medicine is available to those that need it, there's less of a chance of somebody trying to get it for in ways that are in a diversion sort of way. Sometimes routine searching and monitoring of the facility can be helpful of the individuals or their cells, reducing the presence of unauthorized medications, and then obviously close monitoring of patients that are on the MAT program. And again, we've had individuals that have diverted medication that we've been prescribing within the correctional facilities, and we just have a very low tolerance for that, right? We want to make it available to them, but if we catch them diverting the medication, they no longer can get the medication. And so, again, we're really trying to prevent this from happening. And then sort of this multidisciplinary collaboration. Again, medical staff, corrections officers, addiction specialists, sort of having a comprehensive approach to managing the medication and preventing the diversion can be helpful. Essentially trying to get everybody on the same page. Excuse me. I did include this educational sheet. It just shows how we recommend that patients take the medication. Again, 30 minutes beforehand, we're trying to make sure people are not eating, drinking, smoking. Really, nicotine products are probably the most important because the absorption of this medication is in the mouth. So trying to avoid that. Might have them rinse their mouth out once before they take the medicine, put it underneath their tongue, allow it to dissolve, let it fully dissolve in their mouth. And once the medicine is fully dissolved, essentially we're done taking the medication. You can spit the medication out, rinse your mouth out once. There have been some issues with this medication, long-term use of it being hard on people's teeth. So we do need to encourage patients to at least rinse their mouth out, maybe brush their teeth an hour afterwards. But for certain individuals, the Suboxone, because it sits in their mouth on their teeth, can be really hard on their teeth over a period of time. All right, we're getting close to the end here. Let's talk a little bit about some of the safety of the medication and some of the benefits, and then I'll try to address a couple of questions that came out in the initial presentation of this. So from a safety standpoint, every time I see a new patient that's starting on medicated assisted treatment or Suboxone for opiate use disorder, I always tell the patients, hey, I really want to help you in two ways. One, I want to help you accomplish your goals. So if your goals are to stop using substances or not return to use or not go back to jail or whatever, I want to help you accomplish those goals. And then I want to make sure that I'm keeping you safe in the process, right? I want to make sure that you're safe on the medication. And just want to highlight again, the Suboxone in itself provides, excuse me, safety for patients and inmates essentially in multiple ways. One is the ceiling effect, right? We talked about that. No matter how much you take, you're not going to cross the threshold of overdose in a patient that has, a substance use disorder. There's a high affinity for the opiate receptor, so it sits really tightly on that opiate receptor. So once we've started somebody on Suboxone or buprenorphine, even if they had somehow got their hands on fentanyl while they were in the correction center and used that, if they have the Suboxone in their system, it's going to prevent them from overdosing in that situation. So it has this high affinity that blocks the other opiates. And then again, the naloxone component is what prevents the abuse of the medication, both through injection and snorting of the medication. Another sort of safety component is that research indicates that individuals who are released from prison are significantly at risk for opiate overdose, specifically within the first 2 weeks following release from incarceration. The National Commission on Correctional Healthcare, in their position statement, they note that the first 2 weeks post-incarceration, people without medication for opiate use disorder have a 40 times higher risk of overdose than the general population. So again, just sort of highlighting the unique opportunity that we have if a patient is incarcerated, of getting them the help that they need and really helping them, preventing them from overdosing when they get out of incarceration. So again, just because somebody's been incarcerated for a period of time and they're no longer dependent on opiates, or they no longer have a tolerance for opiates, it doesn't mean that we've actually treated the underlying disease process, which is sort of indicated in all these rates of people that continue to go back to use and recommit crimes and do things like that. But again, if we can initiate patients specifically before they get out, we're really helping to prevent them from overdosing, and really giving them a good opportunity to get the help that they need. What are the benefits for the of medicated assisted treatment for the correction workers? Again, there's maybe several benefits, not only just for the inmates, but for the correctional workers and maybe the overall correctional environment. One of the advantages, it can reduce violence and disruption. So providing medicated assisted treatment can lead to a calmer prison environment. Inmates who receive effective treatment for opiate use disorder may experience fewer withdrawal symptoms, reduces the likelihood of agitation, aggression, violence. Again, when patients are in a withdrawal state, they're very unreasonable, just because they're feeling so sick and so terrible. So if they have this option, it's going to be really helpful for them. Again, improving health and safety. So managing opiate addiction can decrease incidences of overdose deaths, help complications, again, help overall safety and well-being of the inmates and the staff. It can decrease the risk of disease transmission. So again, offering medicated assisted treatment decreases the likelihood of drug sharing practices that can lead to transmissions of HIV, Hep C, again, protecting workers as well as the individuals that are there. Enhances the rehabilitation opportunities. If an inmate receives MAT, they're more likely to engage in some of the other rehabilitation programs that are available. Excuse me, and this can definitely lead to better outcomes, and specifically around the recidivism we talked about, and helping people reintegrate into society. Reduces the stress and workload of staff. So again, providing effective treatment options can help minimize crises that the correctional staff may face, overdose situation, violent outbursts, more manageable work environment. Again, I say that with also the reality of like, hey, this medication is an observed dosing medication, right? So in some ways we are creating more work around the taking of the medication, but hopefully overall we're making it a better environment and helping people. And then growing positive relationships, implementing this can foster a positive relationship between staff and inmates, where maybe the perception of the inmates is they're being treated with respect and given legitimate medical care. And this may increase the overall morale and cooperation among individuals. So again, those are some of the things that, from different organizations, CDC and the Centers for Association, different organizations have recommended these things as being benefits. So, all right, so that's essentially the end of the presentation. I'll try to answer just a couple of the questions that came up in the initial time. One of the questions essentially is, why are we initiating someone on a medication that they're going to become dependent on when they're incarcerated and they're currently free of substance use? Like why would we want to start somebody on a medication like this? And essentially, the answer is really that the view of the disease process and understanding it as a chronic disease process that often has remitting, relapsing components to it, is that once someone is out of a controlled environment where they have access to substances again, the percentages of people that are going to go back to that truly have a substance use disorder is extremely high. And so what I'm pushing for is that these patients have an opportunity to have the appropriate treatment when they get out. Now, if an individual doesn't want to be on Suboxone, there are no way are we trying to force someone to be on this medication, but I do want them to have the option of taking it. And again, I work on a little different side of the correction center. I work on the side where people are coming out of corrections, they're in a work release, and they're coming to me and they're saying, please help me not use substances again. I have significant cravings. I know myself. I've been through this before. in the right set of circumstances, if I'm around a drug, I am going to use it. I need help. And so, again, in those individuals, even if it's been a long period since their last use, we can still initiate them on the Suboxone. It's going to help them with their cravings and desire to use. Because it's going to give them steady dopamine, and it's going to prevent them from overdosing. So even if they do get in a situation where they use fentanyl, the Suboxone being on board is going to help block that and prevent them returning to use. Um, Again, I'm not against other services. Actually, I'm for other services: therapy, counseling, mental health, all of those things. And I think even being on Suboxone stabilizes patients where they can reach that component of being able to do those things. But essentially, that's why we're trying to make it available, is to give them the treatment that they need if they have a substance use disorder. And then another question was, hey, where do you send people after they've started on Suboxone? Let's say that we do start them in the correction center and then now they're released. Like, where do we send these people? How do we have them continue the medication? And I think that's a really good question. Essentially, the laws have changed around prescribing Suboxone, meaning I mentioned in the initial story you had to have like specific training and education around Suboxone to be able to prescribe it. Now, every medical provider who renews their DEA license has to do continuing education around opiate use disorder or prescribing Suboxone, and they no longer have to have a special waiver. So theoretically, any doctor can prescribe it, but it can still be difficult to find a provider. And so I need to do some more work for you to try to figure out what services are available locally where you are and what providers are available. But that's part of our goal, is to educate people and providers on how to prescribe this medication to really help individuals that need it. So I really appreciate your time. I think that's all of the questions that I had. I was going to bring Will back on. He's working with me today just to see if there was any other questions that he had or things we need to address, and then we'll wrap up our time here.
I don't think I have any questions, Ed. Thanks for the great talk. I was just gonna give a quick plug for our project here that's doing this training. Ed is one of the 6 experts on our Project Echo on substance use disorders and pain. We're a grant-funded project that's housed inside the Nebraska Medical Association. And ECHO just stands for Extension for Community Healthcare Outcomes. It's a training model, and there can be echoes on various topics. We've got a great group of experts with expertise like Ed has in treating substance use disorder, mental health conditions, as well as chronic pain. So my contact information is here at the bottom of the slide. If y'all ever have any questions or need some consultation on how to handle some patient issues related to these topics, please reach out to me and I can connect you with one of our experts. Um, and like I said, we're a grant funded project, so everything is covered by the grant. It's all free for you all. And I just wanted to share my contact information there. Anything else for you, Ed, before we wrap it up here?
No, that's great. Thanks, Will. And yeah, thank you guys for just the opportunity to share with you today and talk about this area where we're obviously passionate about trying to be helpful to individuals that are suffering from this. And so we're really thankful for this opportunity.
Thank you.